Diabetic retinopathy screening programs can be broken down into 8 linked stages. 1. Invitation. 2. Screening. 3. Grading. 4. Slit lamp biomicroscopy. 5. Results. 6. Referral and treatment. 7. Monitor outcomes. And 8. Recall standards. For a screening service to be effective, people with diabetes must flow easily along this pipeline across all the stages. Blocks in the pipeline, such as appointment delays, excessive grader workload, or long waiting lists for treatment, can result in adverse outcomes. Let's consider ways to maximise the flow of people with diabetes through this pipeline and minimise the blocks at each stage. Each programme does this before screening is established and during implementation. We'll start with Stage 1, Invitation to Screening. There are 2 key practical issues to consider here: programme location and information management. Firstly, where will the programme be located? We can use evidence to establish the number of people with diabetes that the programme will serve. Screening needs to be accessible, and it should be carried out as close as possible to the population or the diabetes clinics they attend. These could be static or mobile tele-screening clinics. The screening venue also needs to be accessible. For example, some people with diabetes may be in wheelchairs or have poor mobility. If we plan to use optometry practices, it's important to remember that optometrists are running a business and they will need to fit screening and grading into their model. Is there a suitable room to grade in? And will they have sufficient time to grade the images adequately? The benefits of optometry practices include the staff's knowledge of the eye and the accessible locations. Visiting all proposed screening venues will ensure that they are fit for purpose. Secondly, information management. How will we know about our population? Screening programs must maintain up-to-date records of each patient's contact and address details. They also need to manage information about new cases, deceased patients, referrals, suspensions and excluded cases. This may require establishing links with doctors and diabetology clinics. Ideally, a fail-safe officer will be responsible for managing the information using a database. Specific attention must be paid to managing information about pregnant patients who need more frequent screening. Making links with the maternity service can be very beneficial. It's important to know if a patient has miscarried, as it can be extremely upsetting for these patients to be called for trimester screening. Screening services must also inform and empower people with diabetes by promoting awareness of the service and the importance of regular checks. For example, by running eye health education events at diabetes clinics, or by distributing posters and videos explaining screening and why it's so important. Stage 2 is the screening stage. Before any screening program starts, it's important to test the selected screening method. Ideally, a few test patients are put through the whole screening process to highlight any unexpected issues with the patient pathway. Support staff are key to screening. Cameras must be regularly tested and maintained. And information technology staff can be invaluable for resolving issues with equipment and software. Programs must provide screeners with training on how to use screening cameras and perform basic maintenance. The screening team must also be supported to address the day-to-day issues which are likely to arise. Keep a notebook at each screening venue where screeners can record when they've had a problem. Hold regular meetings to discuss issues with equipment and venues. And produce a troubleshooting guide of the issues encountered and how they were resolved. Stage 3 is grading. We must have an adequate number of graders for the grading pathway to work. To maintain high quality and stop bottlenecks, a grader should only review each set of images once and pass on for any further arbitration as needed. Plans for graders' workloads must also allow for holidays, maternity leave and sickness. Workload queues should not be too large, as this can delay referral of cases and lead to sight loss. Long grading queues can also cause stress to the graders, who may try to grade too quickly and not pay enough attention to subtle changes. Stage 4. Slit lamp biomicroscopy. The ophthalmologist for the screening service must assess ungradable images and review patients in a timely way, and unnecessary referrals can cause delays. The slit lamp biomicroscopy report must be followed up for each patient to establish their treatment pathway or recall them back to screening as needed. Stage 5 is the results stage. It is useful to have standard templates to communicate screening results to patients. Clear explanations to go with the results can also be helpful, so that the patient is not unduly worried or is able to contact the programme for further support. Stage 6. Referral and treatment. Before screening starts, programmes must liaise closely with the local eye health service, which will need to be reinforced to manage a huge increase in patient numbers once screening is implemented. Once screening is established, programmes must closely manage the referral links between screening and ophthalmic services. Even in highly resourced settings, eye health services do not always inform screening programmes of a patient's status. Having a fail-safe officer to monitor treatment timeframes and appointments will help to support and complete the patient pathway loop from treatment back to screening. Patients do not always understand why it's important to attend screening and treatment appointments. Phoning them to inform them of the referral, as well as sending a letter or message, will increase the attendance rate. Stage 7. Monitor outcomes. Much of the efficient running of a screening programme depends on the regular collection and review of data on activities, and using this to make informed decisions. It's essential to establish a practical monitoring system that is relevant for the local health system. For example, do not install an electronic record system without training both the screening and treatment teams to use it. Stage 8. Recall standards. Each programme must have clear clinical and administrative protocols on the screening process for the team to follow, and, in particular, to monitor screening intervals. Any timeline breaches of agreed recall intervals may be due to capacity or demand within the programme. Quality assurance is vital for the efficient running of screening programmes. Many issues, for example whether a screening venue is fully accessible, do not come to light until a programme is up and running. Frequent, regular meetings with staff during the first 6 months can help to identify and resolve issues as they emerge. In summary, the practical challenges of setting up a screening service are unique to each health system, but taking an informed and evidence-driven team approach will minimise delays, enable timely decision-making, manage workload, and, ultimately, reduce the incidence of blindness from diabetic retinopathy.